Welcome to Acute Conversation, the official podcast of APTA Acute Care, where we share engaging conversations about acute care physical therapy so you can connect to your profession. I'm Ashley.
And I'm Leo. Today we chat with Rebeca Segraves, Jenna Segraves, Erin Locati, and Ann Croghan. Rebeca is founder of Enhanced Recovery After Delivery. Jenna is an assistant professor in the DPT program. And Erin and Ann are both acute care pelvic and obstetric PTs. Today we discuss the most common causes of maternal mortality, preventative measures and screening tools,
and how we as PTs can be involved. Let's welcome our guest.
All right, welcome to the podcast today. Today we have some returning guests. We have with us Dr. Rebeca Segraves and Croghan, Erin Locati, and Jenna Segraves. Thank you so much for joining us today. I wanted to start off maybe with the origin story of how you came back to our podcast. The first podcast was a great episode. A lot of people listened to it. I think it was a great message that you had to give to our listeners. But maybe why don't we start with Rebeca? How did we get you back onto the podcast?
Yeah, absolutely. Thanks for having us back again. It's been an exciting year. I think, honestly, what probably kicked off this conversation was looking at maternal interventions that are done in the hospital by the rehab care team, looking at it now through the lens of the rehab therapist. A lot of what we discussed was just the access to care that this population had, a lot of the maternal health issues that we addressed in the first podcast and the first talk that we did for the acute care section. We did a webinar educating acute care therapists of how they could treat this patient population. But then we really started to look at how we approach patient care in the maternity unit. And so we just published a paper for the PTJ Physical Therapy Journal addressing maternal health disparities in acute care rehabilitation and why there was this disparate in care and treatment for this patient population. So we're really excited to talk about that, really excited to talk about the number one cause of maternal health complications, which is postpartum hemorrhage. And really that first 3 to 4 days during the hospital admission, especially after C-section, what an acute care therapist could do to reduce the complications of maternal morbidity and then contributions to mortality in this population before those individuals go home. And then they have the challenge of caring for their newborn. So we're really happy to be back and to talk about this important topic.
I'm so glad to have you all back, actually. It's really exciting to talk about just maternal care period in the hospital. I feel like it's something that not a lot of people talk about, or even maybe not a lot of people do in their hospitals. But I'm really curious, like when I think about, hemorrhaging in a patient who's pregnant, I think, oh, like I PT out, right? Like a lot of people would probably think like bleeding, that's a big contraindication for what we do. So I'm really curious to hear your all perspective on like, at what point does PT get involved with these patients? Is it before to prevent? Is it the after to recover? Or could it be both? So I'm just really curious to hear from you all, like, how do we help with something like this?
That's a great question. Yeah. And I think you're right, right? For a lot of acute care patients, if you walked into the room and bleeding was happening, you would immediately like peace out as a therapist, right? Like I'm gonna let the medical team decide. But something that's unique about the postpartum population is that bleeding is considered a normal part of both childbirth and postpartum. So yeah, knowing where that line is where someone's crossing into hemorrhage is really important. So it is normal during a vaginal delivery to lose about 500 mLs of blood, and during a cesarean to lose about double that, 1,000 mLs of blood. And ACOG formally defines hemorrhage as being losing more than 1,000 mLs over 24 hours or having any amount of blood loss where you have signs and symptoms of hypovolemia. And then once you have had your baby, it is normal to bleed from your vagina for usually it's around 10 days, but it's not like set in stone. And that is also a normal part of your body recovering after having a baby. So for me, a real key for deciding when someone is in trouble hemorrhage wise is looking for those symptoms of hypovolemia that could indicate they have lost, no matter what the volume is, they have lost too much for them.
Erin, that's such a great point. I'm so glad you brought up kind of the definition of really what qualifies for postpartum hemorrhage. And what's really interesting as you mentioned, is it's different based on delivery type, which I don't know about any of you, but it still boggles my mind. Me, myself, if I were to have a vaginal birth or delivery, I would be considered having a postpartum hemorrhage event if I lost over 500. But me as the same person, if I ended up having a cesarean section and I lost 800, which is more than what I lost if I had had that vaginal birth, that would not be considered a hemorrhagic event. So I find that really interesting. But what I want everyone to really think about or sort of like wrap our minds around is that it happens a lot. So for anyone who works in the hospital, a lot of times you'll hear the code white. That's not where it is at all hospitals, but that's the most common code that you may hear being called. And for therapists to just think about, well, how many patients have we ever worked with who have lost a lot of blood from, say, a traumatic event or from a surgery that they had? And we're now working with them. What are the expectations that we would expect? Well, they're probably going to have less activity tolerance. We definitely need to screen for orthostatic hypotension. We want to be aware that their heart rate may elevate significantly due to that loss of blood volume. And so, why would we give our services to individuals that have had other hemorrhagic events, but not to this population when after they've had a hemorrhagic event too?
That's such a great point, and I think it goes back to, like, when you mentioned that, I just think we go back to our basic lab value interpretation a little bit too, right? Like, somebody with decreased hemoglobin hematocrit, these are some signs and symptoms you would expect, and here's the implications of it. But in looking at your paper, it blew my mind that 80% of these complications are preventable. So I'd like to talk about that a little bit. So, yes, we can intervene, it sounds like, if the event has happened, but how do we prevent some of these? Because I think it was hemorrhaging, it was hypertensive events. I'm trying to remember the other one. Do y'all remember off the top of your head? Oh, infection. Infection was the other one. So how do we prevent some of these?
And I'm probably going to pick on Anne just because, yeah, she has two patient cases that I have begged her, please talk about these because I think it's really important that therapists know really what to look for being part of that care team that's actually able to do what no one else in the hospital does, which would be a home analysis, right? Even from the bedside, we're looking at a population who may not be bleeding out at the time. They're at rest, their food is being brought to them, their baby is being cared for. They can take their baby to the nursery, get rest if they need. When they're going home and no one's actually gone through how to get out of bed if you had a C-section, maybe how not to hold your breath and potentially cause a tear to happen that otherwise wasn't there. Maybe here are some mechanics that you can use to go up and down stairs, or here's the energy conservation strategies before you stand in the shower and maybe exert yourself, just getting in and out of a tub. We underestimate as a medical team the value of having an occupational physical therapist do that task analysis of the patient at bedside in the context, in the environment that they're expected to return to. And so, 80%, just sit on that for a minute, 80% of maternal mortality, and that was also across states. And so each state has their maternal mortality review board, a board of physicians, of public health officials, of nurses, of maternal care team providers, looking at the causes of death in a given year. This is what they do annually, and this data is published annually. When you look at 80% of these cases being preventable, you have to now go back to my hospital, which actually tracked infant drop rate and maternal fall rate. Those are preventable as well. Those are preventable conditions or injuries that have happened as a result of maybe that blood volume being too low, of maybe that person having a raging infection that no one was able to actually evaluate properly because they weren't being provided an evaluation of their task analysis and the environment that they were expected to return to. Only rehab therapists can really do that part. And I'm going to just ping in to share the cases that she was able to intervene within the first week after birth as she's willing. Thank you.
Yeah, so I'll start with the first one, and then Rebecca, I have so many cases that you might need to remind me of the other one we talked about. But the first one was this mom who, like right after her birth, she started hemorrhaging. So it was a known hemorrhage. And she did have a blood transfusion. She was seen in the hospital by our rehab staff. She had vitals taken with activity. And those vitals were not hypotensive, they weren't hypertensive, they were fairly normal. I am a part of a team that goes to a mom's home after she's been discharged from the hospital. And so this mother was discharged from the hospital, and I was able to go see her the next day. So on my way to her house, I called our acute care PTs and I asked for her vitals that were taken while she was in the hospital because they had alerted me that she had hemorrhaged. And so I wanted to go into that visit knowing all of the vital information. So when I got there, so when she discharged, remember, she was completely within normal range on her vitals, and I saw her just a day later. Not it probably wasn't even 24 hours later, and her vitals were trending up towards preeclampsia level, which is technically defined as 140 over 90. Her her numbers were 138 over like 85. So technically not preeclampsia, and her heart rate was in the hundreds. So I talked with her. These were vitals that were just resting, by the way. I did not see a need to do activity vitals. I told her not to do her stairs. She needed to stay close to her bedside. I left that visit, called her doctor. Her doctor had her come in right away for an assessment on our OB floor. So she went to labor and delivery and they did her vitals, which again were still not quite preeclampsia level, but they also ran a urine test and she did have preeclampsia. So we were able to catch that preeclampsia before it progressed to hypertensive and also able to make better activity recommendations, until she got the care that she needed. I would have not been so concerned on those numbers had I not had the acute care numbers, had I not known where she was when she left the hospital, not 24 hours later. So those vitals are really important. And, even if in the moment they don't seem as useful, when we get to see moms when they're discharged home and able to catch preeclampsia before it becomes a major hypertensive event that leads to a stroke, and an infant that loses its mother, this is just really important to catch these things early. So I feel really blessed to have that opportunity and thankful for our acute care PTs for following through and taking those vitals.
Something I want to layer on top of Anne's is I've seen patients they have known preeclampsia coming into birth, but then they lose a lot of blood during birth. And, preeclampsia causes your blood pressure to go up, but blood loss causes it to go down. So you could miss somebody who maybe is still preeclamptic postpartum because you're having these opposite forces on their vitals from the hemorrhage. So it makes it really complex, I think, caring for this population. You really need to pull in as many variables as you can. And to go back to your question, Ashley, about can we prevent hemorrhage as therapists? So the most common cause of postpartum hemorrhage is something called uterine atony, right? So after you have a baby, part of your uterus where the placenta was attached, the placenta comes off and the blood vessels that were interfacing there are bleeding into your uterus and blood's coming out of your vagina. That's the source of postpartum vaginal bleeding. And it takes time for your uterus to contract postpartum to clamp off those blood vessels. So if your uterus is atonic and it's not able to contract like you need it to postpartum, that bleeding doesn't get slowed down and you can lose too much blood in the postpartum period. So as a therapist, right, my question then is, well, what makes the uterus not be able to contract like it needs to? And some of the big risk factors are if you have a labor induction, especially if it's prolonged, because you're essentially with induction giving a mom medications that artificially make her uterus contract. So the contractions could be too prolonged or too forceful, and you basically poop the uterus out, right? Or if you had a really long labor, that could have a similar effect. Preeclampsia puts you at a higher risk for it. Having placental abnormalities during pregnancy, like a placenta accreta condition, can increase your risk. So as a PT, I mean, you can't necessarily do anything after birth to keep someone from having been induced during their birth or to have kept them from getting placenta abnormalities during pregnancy. But on the prenatal therapy side, you can, as a PT, do a lot of training with somebody around birth prep to reduce the risk that they're going to need to be induced or to help their labor not be just so long and drawn out that their uterus is really pooped out afterwards. And that's something I know that Anne does also, the birth prep stuff.
I would disrespectfully counter that, Aaron, because I think that the messaging may be a little unclear as to, well, there's not much that we can do if a person is at risk for postpartum hemorrhage. A lot of times, we fail to really recognize the data that's collected by the CDC is that postpartum hemorrhage risk is for several weeks after delivery. And so if you're looking at a risk factor, that's the number one risk factor in terms of maternal morbidity and then mortality, the number one contribution to postpartum hemorrhage being cesarean section, well, then there's a lot that we can do, again, in that task analysis in the environment that that person is returning to. If this is a single mom and she has several steps, like we talked about in the very first podcast, and, with Ashley and Leo, we have to really use our social determinants of health to really understand what makes these individuals at risk for bleeding out after that initial phase of where everything seems to be controlled, the bleeding seems to have stopped. Well, then what are they going to be returning to that might actually cause maybe a suture or maybe a tear to actually get worse, or maybe the healing to slow, or maybe that those muscles to stop contracting or get the ATP that they need. We can look at really the muscle physiology of what's going on and really help that individual navigate a very physically demanding time, which is the first 6 days after they deliver.
I was just saying that's a great point, right? Mhm.
So I wanted to ask because on our first podcast, what kind of really stuck out in my head was this idea that for a C-section, it's an abdominal surgery, and PT is not a standard of care. It's not automatically, PTs are not automatically consulted. I don't know how many times Whipple procedure, abdominal surgery. I've even been consulted if somebody had their appendix removed, right? So I just make sure that they're able to, in terms of, it's just part of its standard. So I just wanted to ask, what is the standard right now at, some of the places that you work at, and how, is there any work that's being done to maybe change that standard of care? Because just hearing you kind of mention how much we as physical therapists can do from the, in terms of peripartum and postpartum, there's so many different places where we have value, where we can add value for our patients and our clients' care. And so again, what's the standard of care right now, and what are some of those barriers? Oh, Jenna's reaction. She's like, "Whoa! All right, one question at a time. One question at a time, right?"
Well, I will say that's a rather loaded question there. So, current standard of care is nothing. No rehab, nothing. This person just had a baby. What's the big deal? And that is unfortunate because out of really all developed nations, the United States has the absolute worst maternal health outcomes, not just by a little, by a staggering amount. We are about 3 times worse than the second worst country
Mhm.
out there. And it's abysmal, seriously. It really is. But this is something that, I don't want to just be on this negative side of things because I really like to instill hope
Mhm.
and really let everyone know that this can be changed and it can be changed in a lot of ways. So we are trying to make this more standard of care. Rebecca actually tracks how many hospitals currently offer services to individuals after a cesarean section. And I think we're at what, 42, 43 hospitals out of how many hundreds of hospitals that there are in the United States. So, really trying to help other therapists to realize that, hey, I know you may not feel comfortable with this patient population because it's not standard of care, but you work with individuals after abdominal surgeries all the time. And this is not just an abdominal surgery, this is a major abdominal surgery. And now there's usually another life on the other side of it that this person now has to care for. So they're not only healing from their own surgery, they now have a newborn and they may have other children and or other responsibilities within their home. And how can we help them to succeed in this recovery afterwards? Well, we can start by simulating their home. We can start by just helping them learn the safe ways to mobilize while protecting their incision, just like we would for anyone after any other surgery, particularly any other abdominal surgery. And as Anne, really brought up the importance of vitals and how this can play a huge role. We know that again, the maternal health of this nation is not great. And most of the deaths or other comorbidities that occur take place postpartum. So I do think acute care therapists can play the most critical role at being able to identify potential barriers to that person succeeding because we ask those pertinent questions about social determinants of health, their home environment, their level of support that they're going to have. We have great relationships with social work to make sure that they can try to get any of those resources that they may need. And if everything is going well, they actually, I don't want to just sound so negative because sometimes they may have a great support system. They may have no barriers. Well, we can be that first voice to let them know about what to look for and when to seek out continued services, whether it's outpatient pelvic therapy, whether it's going back to their physician, whether it's going back to the ED. So there's hope. And so I don't want to just be, coming in angry because I am. But I also, I want everyone to just know we belong here. And as acute care, physical therapists, we also strongly advocate for occupational therapists as well. But we belong in this realm, and it really can start with you. It can start with you.
You all sing my heart song when you talk about the importance of vitals. And I really think Anne's story just really resonates at how important they are, right? Not only just taking them, but also understanding the trends and knowing that some of these hypertensive issues are, some of the preventable ones for this maternal mortality. And we know that exercise can actually help lower blood pressure in general, right? So, like, you always think about the after, like, because I'm even somebody who, after I had a child at my first postpartum visit, they were like, you should go see a pelvic health therapist. And I was like, yeah, I probably should. Right. But like, no one mentions it or talks about it beforehand or like even educates you on like how could you prevent this, or what are some issues that may arise, or when should you see one? So I think these are all really great, important points. But I also wanted to go back to the article because you all have brought up several times the social determinants of health. And I think thinking about that is very, very important. And in your article, I feel like there were several practical tools that you mentioned that could be used to help along the way. So I'm just curious, what are some of these tools that therapists could use out there to try to maybe improve some of these outcomes and just be aware of what some of these determinants are?
Absolutely. The major tool that, we introduced in that article was more of a along the lines of implicit bias. There was a study that was recently done, and it'll probably be published in 2025, but it'll definitely be presented at CSM. But we worked with a team from San Diego State University, and they were looking at the perception of acute care therapists to treating this patient population, and then OBGYNs of referring their patients during hospitalization to acute care therapists, physical therapists for rehab after a C-section or after a delivery of any type. And so it was an implicit bias tool that we used for acute care obstetrics rehabilitation to really determine, were we using outcomes to decide whether or not we could be of service to this population along the same lines as you would use the AMPAC 6 clicks to determine what level of help does this person need to get out of bed, to go and to negotiate stairs, to stand up from a seated position, to get out of a flat bed. I mean, those are all those things that are just clearly defined when using outcome measures versus your gut feeling, versus maybe those biases that you hold that this patient is healthy and they're not a priority in this acute care environment. I have someone maybe on a different unit that is more worth my skilled services? What are we using as acute care therapists to determine if this patient population would benefit from an evaluation, which they could further determine the plan of care that we develop for that individual, the discharge planning. And so that was the first time that we've introduced anything like that. And it was an aha moment for us in saying, well, the rest of the tools that we're actually recommending are just evidence-based outcome measures that our acute care therapists have a lot of access to. Is that once you actually now know, like, hey, I actually have these perceptions, and it's because of either limited access or my own experience or whatever it is that not is not allowing me to go onto the unit to work with that team to, explain my services, to communicate my worth and value to this population. Once you have actually noted that or recognized that, now you're actually using outcome measures, evidence-based outcome measures with this patient population like you would on any other unit in the hospital. And so I think that was kind of the biggest thing that we focused on in the paper was enabling therapists with a tool that could really either address their own implicit biases, but then having them use outcome measures that they would use in any other case with any other patient population so that they were actually basing their decisions on evidence and not their own gut feeling.
And just to add a little bit to that, another thing that, because I believe, Ashley, you had wanted maybe a little bit more detail about how to screen for some of the social determinants of health. So a lot of
Yeah.
that comes with, yeah, a lot of that comes with just our kind of patient interview process that I think most acute care therapists feel really comfortable doing. We do this with any patient, any condition. We do a deep dive into, again, that home environment. What's their support system? What was their prior level of function? What are their responsibilities when they go home in terms of ADLs or IADLs? Well, we're doing that for this population too. Even though they're, we tend to view them as young, healthy, independent. They may be more active than the typical patient that you may see in the hospital environment, but that comes with more responsibilities a lot of times. Some of these individuals may have financial constraints and concerns, and they're planning to go back to work within 2 weeks. Well, after a major abdominal surgery, such as a cesarean section, is that the best idea, or is that really even our place to tell them not to? And if they're going to go back, then we can step in to try to help make sure that they're able to navigate that in the safest way for them in order to protect their incision. We can teach those, ergonomics, body mechanics, all of that. But it starts with asking those questions about, do you have other children that you're caring for at home? Because that's going to play a huge role in how are they going to navigate their weightlifting restriction of 10 pounds if they have a 1.5-year-old as well, in addition to this newborn too. So, Anne, I'll let you add
Yeah.
on.
So I wanted to add on because I think stories are really important. So recently had a case where a woman had an unplanned cesarean. She was sent home. She lives on the third story of an apartment building. She does not have any help. She had bilateral wrist pain, Decker veins, so she could barely hold her baby. She had to get her baby a car seat and a stroller up and down 3 flights of stairs. So these are the questions we have to ask. How many steps do you have to take to get into your house? You ask that for everybody else. And so we have a woman who I have no idea how she managed this without dropping her baby down flights of stairs because was trying to manage all of this. And it just took her and I sitting down and developing a plan and having a conversation about how we were going to help her get in and out of her home because she needs to get in and out of her home. How can we have groceries delivered? What sort of services can we help set up for her? Because remember, she is doing this all alone. And so, yeah, it's just really important. We just ask. If we ask, then we'll be able to figure it out and how to help them. Yeah, and I think too, also remembering this death by suicide is one of top maternal mortality. So, like, this woman is at a really high risk of suicide just because of this struggle component that she has to also work through. So how can we help prevent that? Well, we can help screen her and get her services so that maybe she feels a little less alone.
So I'm thinking about, I have students, and many students might have never thought that they would have liked acute care. They're like, Dr. Leo, I think I'm going to go into pelvic health or maternal health, but I also like acute care. And so now just listening to this podcast, I'm like, we can meld the two. Like you can make your job, and this is like the perfect opportunity. So what would you say to those new grads or soon to be grads that are out there that really like acute care, but they also like working with the OB/GYN peripartum population? How would you start getting, and if it's not standard of care in their hospital, right? Where the only time a therapist gets consulted is it somebody did have a delivery and there was maybe nerve damage. Now this person's not able to walk because of some nerve damage. That's where I've seen PTs that are consulted, but it's not standard across the board. So how could they enact that change?
Leo, I think that question's so timely because we just had in our lab where students, it was like listed all the specialties and the
Hmm.
students have to put their names under the ones they might be interested in. And I was really surprised to see how many names were under pelvic health. And then there was quite a bit of names under acute care too. So I'm like, oh, if we had
Yeah,
combined those, but
let's,
yeah.
let's put them
Anyway, I want to
together.
hear your answers to the questions.
Mhm.
This is me, right? This is my, I did not think acute care was what I would want to do when I graduated PT school. Uh, but
Students, listen.
well, okay, this was my experience that in PT school, outpatient ortho is really up on a pedestal, right? As being like, and for a lot of people, that's why they got interested in PT, right? They were student athletes, they got injured, right? And so that's kind of how they got interested in therapy. And acute care is sometimes perceived as being the least skilled setting, right? Because you just walk people,
Ooh,
right?
ouch, out, cringe.
Eyes
Cringe.
towards
Aaron, I'm going to stop. I'm just going to have to be quiet, right? Like,
right.
You went to
And
AFib right now, Erin.
you know, sure, I'll take our vital signs. It's really fortunate I did a rotation in acute care, primarily in ICU. So I saw just how complex it was, especially your decision making, right? I mean, on the
Mhm.
outside, maybe it looks like I'm just transferring this person to the edge of the bed. Well, how is that skilled? But there's this incredibly complex decision making process
Yep.
and monitoring process that you are constantly doing in your brain that factors in a lot of things. And that was when I started to really be interested in acute care. And when I had my kids, I didn't know anything about pregnancy and postpartum. Like, I didn't know what a cervix was. My doctor would talk to me about it. And I'd be like, I don't know what that is. I know it's up in there, but I don't know what it is. Right. And I had my kids and went, "Holy crap," right? Like, for a lot of people to get into pelvic therapy, that's their origin story too, right? They have children, they realize how much of a gap in knowledge they had, even as a skilled physical therapist around this population, and
Yep.
then they start pursuing a pelvic specialty. So, that's what I wanted to do, but I loved being in acute care, and I didn't wanna leave acute care. So, I was like, "Well, how could I do acute care stuff from where I am now for pregnancy and postpartum?" And I'm like, "Well, everybody's here in the hospital having babies. Why can't I go see them there?" And that's really when I started to work on trying to get in to those units to see those patients. Though I would say I use pelvic therapy knowledge in acute care for all my populations. Like, I'm forever talking to people about their peeing and pooping habits in the hospital because they get all jacked up in acute care, right? And they have huge quality of life and even safety implications for people. So the idea that we should be like siloed into like, well, this is acute care and this is pelvic health and this is ortho and this is neuro is not really how real people live their lives. Like, real
Right.
people have orthopedic systems and neuro systems and pelvises, like they have all of that happening at once. I think you do a disservice to your patients when you sort of silo your mind into one specialty and one specialty only. And one of the things I love about acute care is it really pushes you not to silo yourself
Yeah.
because you will see every patient population, every diagnosis, and you have to be able to provide competent care to all of them. So I really think of acute care as being not the least skilled, one of the more skilled settings because it requires you to integrate knowledge from so many different specialties that tend to be siloed when you're out in like outpatient settings.
Mhm.
But if you're at a hospital that is not part of the 43 that right? And you want to get in there to see the OB population. Great places to start are talking to your supervisor, right? Talking to whoever's in charge of the OB unit at your hospital and talking to the nurses on those units. Because
Mm,
nurses are really great generators of orders, and
yeah.
having them on your side makes it so much easier to get the doctors on your side and to get into that unit. And I'm going to let other people talk about other things to do to get in the unit and to up your own knowledge and skill if you didn't come out of PT school with knowing about pregnancy.
First of all, I just want to say amen, sister. It is the most complex.
Yeah. That's the skill. That's where the skill comes in.
Well, I would like to give you all the platform if there's anything else you want to say, but I also just want to say, because we will have to transition to rapid response soon, but I remember one of the most heartbreaking patient cases I had when I worked in cardiothoracic surgery, and it was a patient who was pregnant, but then had all of these complications after pregnancy, and the mother didn't make it, and it literally tore my heart out of my chest to think about that kid and that father having to go home without that mother. I'm going to get emotional just thinking about it now. But to me, I just want to thank you all for what you're doing, for bringing
Mm,
people's attention to this, for getting
yep.
this out there and to trying to advocate for more hospitals, honestly, outpatient clinics anywhere to get involved in peripartum, postpartum care, because I feel like any difference we can make is a huge one.
And I wanted to add too, Ashley, is that what I love about being an acute care therapist is that sometimes you're that bridge. Like Anne, you were saying, like maybe after you do the interview, you do notice that there are these social determinants of health. Well, let me go consult are you okay if I talk to the social worker? Or there are these services, or there's people that can help out. So being that person, even though right then and there you're not doing a specific intervention, right? We're not. Oh, we're going to strengthen the last. Sometimes it's your ability to be able to see those opportunities and be able to connect people with the right resources. And that's also part of the fun of why I love acute care is sometimes that you're just the right person that has these connections and you're able to connect the right people together. And maybe even as an acute care therapist, that's not a pelvic specialist. When this patient transitions to home, it's like, you know what? There's some pelvic health therapists that I know that work at this clinic. They'd be great. And I think you would benefit from the services, right? We do the same thing for vestibular, for ortho, for cardiopulm. It's just, I think this is an underutilized resource in terms of our ability to be able to make those connections within this population.
Well, and to me, this is the one where how often do you to make not only the difference in one person's life, but in a brand new person's life as well.
Yeah.
You're influencing two lives as a result of the care you're providing.
Before we transition to rapid responses, Acute Conversations has an important announcement. Ashley Poole will be leaving our team at the end of the year. We will certainly miss her insight, her passion, and her humor. This means that we are seeking a new co-host. If you have interest in joining our team, please email the show so that we can meet with you and determine if you would be a good fit. We only have 2 episodes left in 2024, so contact us soon. And now, back to the show.
I think with that, Ashley, I think it's time for our rapid responses.
I think it is. Are you all ready for this?
Are we targeting single
We're gonna have to call out a name and just rotate around because
Lord,
yeah.
let's do it.
Yeah.
Let's do it.
All right. I'm gonna start the timer. I'm gonna give a little extra time on this one since there's so many of you. All right. You ready,
And remember,
Leo?
the first thing that comes to your head, spit it out.
Okay, and go.
All right. Rebecca, what's your most favorite dessert?
Peanut butter cookies.
Boom. I love it.
Vegan.
And what's your favorite way to exercise?
Ooh, I like going hiking.
Awesome. Erin, what type of shoes do you wear on acute care in the hospital?
I wear Flux waterproof sneakers. They're amazing.
Nice.
You can spray a hose on them and it won't go.
Great.
Jenna, do you have a book you'd recommend to our audience?
Oh, I do. It is How to Make Friends and Influence People. I might have said that a little bit wrong, but that is an excellent book. It has those words somewhere in that order.
And name an influential PT that is changed your life.
Ooh. Penny Smicken.
Awesome.
Becca, what's your favorite holiday?
Thanksgiving for sure, hands down.
Jenna, what's your favorite scrub color to wear in the hospital?
Teal.
Teal. Ooh.
Mhm. Erin, do you have another podcast you'd recommend?
Yes. A slight change of plans with Maya Shankar. So it's not therapy specific, but it's really amazing about the decisions we make and how we think about things when something big happens in our life and we have to change course unexpectedly.
All right. And with that, we're at time, but you all have to answer this. You know you work in acute care when fill in the blank.
There's donuts on every unit.
It's dangerous.
Where's the call bell?
Right.
You have sneakers that you can spray with a garden.
Right.
You're always taking vitals.
All the time. All the
Oh,
time.
what a nice one to end on.
Very cool.
Thank you all so much for being here again. And honestly, I feel like we'll probably have you again at some point because I feel like people can't hear this enough. Thank
Is
you
there
all.
is there anybody you want to maybe just throw out there, any social media? So our listeners out there that wanted to contact you, if they had questions or just wanted to reach out and maybe start a conversation, how can people find y'all?
I think most of us have social media. So you can find me on Instagram at Erin Locati _PT. And there's also a Facebook group that Ian and I moderate that's really excellent. OB, PT, and OT.
Oh, perfect. Thank you.
You can find me on LinkedIn. Just my name, Dr. Jenna Segraves.
Awesome.
Same there. Yeah, same here. LinkedIn, probably all platforms. Rebeca Segraves.
Awesome. Well, again, thank y'all. Thank y'all for coming back on the show.
Yeah, thank you.
Thank you.
Awesome.
Bye.
Bye.
We would like to thank Jenna, Rebecca, Erin, and Ann for joining us on the podcast. Acute Conversations is the official podcast of APTA Acute Care. It is hosted by Leo Argulis and Ashley Poole. Executive produced by Katie Brito and Edward Mathis. Music by Alexia Action from Pixabay, sound effects also from Pixabay. For more information about APTA Acute Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us in 2 weeks for a conversation with Mary Fisher and Christine Joseph about screening for falls. Thank you for listening, and may your shoes and scrubs stay clean today.
The more we can have these conversations and normalize this
Yeah.
type of care, it'll help more acute care PTs feel empowered, to bring this care to their facility. So it's
Right.
not just such an anomaly, but I think the more they hear it, the more that they'll feel inspired.
Yeah.